we should try and biopsy because you have a hepatocellular carcinoma, but we know that some of our patients may actually have a hepatocholangiocarcinoma, which may have similar radiologic features. And also with the next generation sequencing coming in, if we are able to identify a target, then obviously we can hold the hand of our patients for longer, especially if we can find a simpler target for which we can repurpose a drug. So I think biopsy is quite important. It should be in our mix, and we should all be aware about the liver radiologic criteria, the LIRADS. I'm sure you're all aware about it. If not, you should read about it. So I think the treatment modalities for HCC, I'm only going to discuss unresectable HCC, where you have systemic therapies. When you have the intermediate, early intermediate or advanced, but it is liver limited, you have intra-arterial therapies. And I have 2 slides at the end to talk about intra-arterial therapies because there's quite a lot of data with sorafenib revolving around those intra-arterial therapies. So I'll just discuss those very briefly. So in 2020, I think these are the treatments we will be talking about, and first line treatment, second line treatment, and there is data on some for third line treatment. We know that about 50% of our patients will go on to second line treatment, and about, I would say 10 to 20% in HCC fit young patients may go on to third line treatment, but the number of patients is much lesser than other GI cancers, I would say, in HCC, because the liver in most of these patients is decompensated. So the first line, and the treatments are divided into tyrosine kinase inhibitor or the VEGF pathway or the immunotherapy pathway. So you have the targeted treatments, sorafenib, lenvatinib. I'll talk about them in first line. And also the bevacizumab and atezolizumab, which has recently been approved. Various immunotherapies and second line treatment with regorafenib, cabozantinib, and ramucirumab. I will not talk about cabozantinib and ipilimumab because these are not available in India. I think this was the pivotal trial more than a decade ago, which showed that there was a survival benefit of about 12 weeks with sorafenib 800 milligrams versus placebo in patients who had unresectable HCC. All these patients had Child-Pugh A HCC. The median overall survival, both in Asia-Pacific group of patients and in the SHARP trial, was pretty similar. The survival is shorter in Asian patients, but very similar hazard ratio. So there was an improvement in overall survival to about 11 months compared to 7.9 months compared to placebo. And the benefit was seen in patients with extrahepatic disease, those with a hepatitis C infection, and so all the groups, actually subgroups, benefited with sorafenib. But the greatest survival benefit was seen in those patients who had HCC. The median overall survival was 14 months compared to 10.7 months. So I think the data has been consistent with sorafenib, that it works in first-line HCC patients. There is no significant effect in combination with TACE. So there are 2 trials which were negative. There is absolutely no benefit as adjuvant therapy, post-resection or ablation. So a lot of times I get a lot of patients from our interventional radiologists. They say, "Man, we've done the TACE or TARE. Could you please start the patient on sorafenib? Otherwise the patient is going to recur." Actually, the STORM trial did show that there is absolutely no benefit of giving adjuvant treatment post any of these strategies. So it should not be given. So it was still a decade. From 2008 to 2018, we only had sorafenib, and a lot of these trials were ongoing. So the REFLECT study actually compared lenvatinib versus sorafenib, which was the current standard of care at that time. And with lenvatinib, the phase 2 study had patients on 12 milligram of lenvatinib. And I think dose reduction was done in almost 75% of patients, and about more than 30% patients discontinued lenvatinib because of toxicity. And the main toxicity with lenvatinib, which led to discontinuation, was proteinuria. So it behaves like any other VEGF inhibitor. So the class effect of hypertension, proteinuria, diarrhea, rash, and other side effects. So I think for the phase 3 study, they went with a dose of 8 milligram in patients who had a body weight of less than 60, and 12 milligram in those who had a body weight of more than 60 kilograms, and randomized to sorafenib 400 milligram twice daily. Now with sorafenib, when I was in Tata Hospital, I remember we should have published that paper actually. We never did. But I analyzed the data, and what I realized was that the hand-foot syndrome in our patients was quite significant with 800 milligram. And very few patients actually tolerate this dose of 800 milligram. Most of our patients would tolerate maybe 600, 400 to 600 milligrams daily. Very few, you'll have 10 to 20% who would be on 400 milligram twice a day. So again, the groups are very well balanced. There were a couple of about 8 patients who had Child-Pugh B category as well. So as you can see, there were about 19% patients with hepatitis C. A majority were those with hepatitis B. There were patients with more aggressive disease were seen in the lenvatinib group, AFP more than 200, 46% here and about almost 39% here. So there was slight imbalance according to the study authors. Again, we know that patients with hepatitis C tend to do better with sorafenib, and these were overrepresented in this study. There was no stratification done. So as you see, the study did not meet its primary endpoint. The curves are literally on top of each other, but the lenvatinib curve is slightly on top, but it is not statistically significant. The median overall survival was 12 versus 14 months. Not statistically significant, but numerically longer in patients with lenvatinib. I don't know what the significance is. So the progression-free survival with lenvatinib was double. It was significantly longer. And also, if you see the overall response rate, especially in patients who have a high tumor burden, was almost 3 times more with lenvatinib than sorafenib. And if you see now this is not very clear, but what this slide shows is that the poor prognostic subgroups, like those with the macroscopic portal vein invasion, or those with an AFP of more than 200, or those with hepatitis B. So the dot is more towards favoring lenvatinib, but again the confidence intervals are quite wide. So I don't think we can take major conclusions from this. Most common adverse events with lenvatinib were hypertension. With sorafenib was PPE or hand-foot syndrome, which we know about. And about 33% patients reduced the dose, and a few discontinued in both the arms. So, like I said, with sorafenib, my experience has been that very few of our patients tolerate 800 milligram. Again, with lenvatinib, I have quite a few patients on 4 milligrams alternate day. So we, according to weight, we start with 8 or 12 milligram, and from 8 you go on to 4 milligram, or from 12 you go on to 8 and then 4. But I have quite a few patients who are responding very well with lenvatinib, but they are on 4 milligrams alternate day, mainly because of thrombocytopenia or hypertension. So other thing I've seen in at least 2 of my patients in the last year is that these patients have developed arterial thrombosis. And in those who do develop arterial thrombosis, lenvatinib is actually contraindicated. So I had one patient who developed pulmonary artery thrombosis, not venous thrombosis, but arterial thrombosis. But again, this is a side effect of class effect of VEGF inhibitors. So I think whether you want to go with sorafenib or lenvatinib, each of these is different slightly. Sorafenib may probably be favorable in patients with the hepatitis C histology. And the other thing is, in the lenvatinib study, one of the inclusion criteria was that patients who had more than 50% of liver involvement, they were not included. They were not included. So with lenvatinib, you usually prefer it if there is less than 50% liver involvement. sorafenib, any tumor burden is allowed. More of skin toxicity, hypertension with lenvatinib. Now, the other study, which is a first line study, is nivolumab versus sorafenib. The checkmate trials are the Nivo trials. Looked at 240 milligram versus sorafenib 400 milligram. Now, the dose that is approved by DCGI in India for nivolumab is 3 milligrams per kilogram. So again, child PUA, a good performance status. The other thing is the most of the patients that you would see in your clinic would be low child B, I would say. So they would have a child PU score of 7 to 8. So they would be on the lower side, but very rarely do you see patients with the child A criteria. Because by the time the patients come to you, they would have had some form of intra-arterial treatment and their liver would be decompensated. So very rarely you see the trial criteria patients in your clinic. Sadly, the study did not meet its primary endpoint, and the survival was 15 months and 16 months, pretty similar in both Nivo and sorafenib. So it was a negative study. So again, this subgroup analysis doesn't mean much. Subsequent treatments, about 50% patients, which again reflects our clinical practice, do go on to second line treatment. And these were the various treatments that patients had in this trial. And about 3 to 4% patients actually underwent surgery as well. So 20% patients in the sorafenib arm received some form of immunotherapy afterwards. So again, the safety profile was pretty similar in both the arms, especially the grade 3 and 4 treatment-related adverse events was 22% in the Nivo arm and about 49% in the sorafenib arm. So the toxicity profile, the safety profile actually favored nivolumab. But again, I will talk about the costs at the end of the talk, and then and to avoid that, I think the best way is to start with a lower dose and then escalate it slowly. So again, this slide shows that fewer patients treated with Nivo experienced worsening of treatment side effects compared to sorafenib. And probably this is a good option for patients where the VEGF inhibitors, because of arterial thrombosis or uncontrolled hypertension, are contraindicated. So this was the one of the practice-changing studies, I would say, because this regimen was approved as first-line treatment. Patients were randomized 2:1 to atezo 1200 milligram every 3 weeks and bevacizumab 15 milligrams per kilogram every 3 weeks, a very high dose. Sorafenib twice daily. And again, the patient, child A, very similar to the criteria which is used earlier. Quite a few patients had AFP more than 400 as well. So, but very well balanced in both the arms. So this study, this is the only trial actually first line, which has shown that there is something which is better than sorafenib, which has been around, because all the other trials have shown that nothing else is better than sorafenib. So with the median follow-up of almost 9 months, what they showed was with atezo-bev, the overall survival median has not been reached yet, but the hazard ratio is about 0.58, which is pretty impressive in HCC. So significantly better overall survival, and also progression-free survival was also significantly better. It was 4 months versus 7 months, so 3 months longer with this combination. And again, time to deterioration of quality of life was significantly better with atezo-bev. Patients were able to maintain their quality of life. I think probably is related to the progression. Adverse events, again, the adverse events were grade 3 or 4, were pretty similar in both the arms. And in sorafenib, it's mainly related to hand-foot syndrome. I think most of the patients in this trial would have started on 800 milligrams of sorafenib. So I think again, as this slide shows, that this is the only combination which has shown that it's significantly better. It has a good safety profile, but again, these are very fit patients. So one can consider immunotherapy where TKIs are contraindicated. But again, if you consider radioembolization, one has to make sure that the patient has no extrahepatic disease, has a good functional liver reserve, no main portal trunk invasion. Portal vein thrombosis in the other branches is allowed. And also you have to have high MA uptake in every tumor site. Nivolumab, again, these are very standard criteria. If any of the patients does have hepatitis B or C, it should be under control with the drugs. These are the various trials which are looking at checkpoint inhibitors versus VEGF inhibitors, first line. Coming on to the second line treatment options, I think these are the drugs which are available in India except cabozantinib, and I'll just talk to you briefly about these drugs. Regorafenib is approved because of improved overall survival. Nivo is approved because of durable overall response rates. Brivanib, everolimus, the mTOR inhibitor, has failed. Ramucirumab, it failed in the original REACH but was positive in REACH2, and I'll show you some slides on this. So this study basically looked at in second line setting for patients who had documented progression on CT scans. They were randomized to, with good organ function, they were randomized to 160 milligram. Again, with the redose, we know that we should start with a lower dose of regorafenib. We've learned that from colorectal trials. 3 weeks on, 1 week off versus placebo, because nothing was the standard of care after sorafenib at that time. And this study showed that there was a significant prolongation of overall survival, progression-free survival, time to tumor progression. Response rate was almost double with regorafenib and in second line setting. So this looked at sequence of sorafenib and regorafenib, and if patients had sorafenib first and then they had regorafenib, their median overall survival was 26 months. This is all patients who received it. And in Asian patients and rest of the world, pretty much similar, 21 to 26 months of overall survival. So remember, we are talking of 10 months and 12 months with sorafenib alone in the SHARP trial. So, and you can see sorafenib followed by placebo, the survival ranges from about 15 to 20 months. So patients are living about 6 to 7 months longer if they have a sequential second line treatment. But that also shows that they probably have they were fit enough to receive second line treatment. So they select themselves out. The REACH trial, the original one, again, randomized patients second line to those who had progressed on sorafenib to 8 milligrams per kilogram every 2 weeks versus placebo. And this is the same dose that we use in gastric cancer as well. The primary endpoint was overall survival. And basically, this showed that the overall survival was not significantly different. But when they looked at AFP more than 400 versus less than 400, they saw that the benefit was seen more in those who had an AFP of more than 400. And that's where the licensing indication is for ramucirumab. It's a poorer prognostic group. So it probably helps patients who are in the poor prognostic group. So the REACH2 randomized patients to ramucirumab versus placebo for those who had an AFP more than 400, and the primary endpoint was overall survival. And it was significantly better, 7 months, 7.3 versus 8 months, about 5 weeks better in second line setting. All the other parameters were also significantly better. The grade 3 AEs, again, a class effect, hypertension, and hyponatremia was the other one. So again, this pictorially shows all these three drugs. Cabozantinib, like I said, is not available in India, but again, this is the only drug which has been tried in third line, where sorafenib has been discontinued. And in all these studies, hepatitis C, hepatitis B, those with macrovascular invasion, extrahepatic disease, and AFP more than 100 are very well represented, more so with ramucirumab. So looking at checkpoint inhibitors as second line, for the patients who'd been treated with sorafenib before, you have data with nivolumab and pembrolizumab, second line and third line. with response rates ranging from 14 to 17%, and a median overall survival with nivolumab of 15 months and pembrolizumab about 13 months. Again, these are phase 2 studies. Similar thing shown here. So I think since I started training, when we were training, we used to give doxorubicin and tamoxifen in 94, 95. So we didn't have much other than local radiotherapy or the TACE and TARE, which also came by later. So so all of these drugs have improved the outcome for our patients. 3 drugs are approved in first line setting. You have sorafenib, lenvatinib, atezo, and bevacizumab. But I think it's important. I think what we still need to learn, what is the right sequence to optimize the maximum survival of the patients. And I have an expert who's published a lot on this, talking on Friday, actually, Professor Hassan Abu Alfa from Memorial Sloan Kettering. So if you are free, I would urge you to join that session, because we are talking about HCC and gallbladder cancers for just 1.5 hours, 7 to 8:30. So very briefly, I just wanted to show this so that you are able to tell your intervention radiology colleagues that there is no indication to give sorafenib adjuvantly or along with any of these modalities. So 2 randomized trials have failed to demonstrate a superior overall survival after radioembolization versus sorafenib. Again, huge number of patients. And these were the Sirvenib trial, the SARA trial, and the Ceramic trial. You can look at the details of this trial, and the references are at the bottom. And you can see that the response rates, yes, would be higher with the radioembolization, but the overall survival is actually not significantly different. And as with sorafenib, as always, the treatment-related AEs are significantly higher mainly because of the hand-foot syndrome. Similar thing shown here, that the overall survival is pretty similar in all the 3 studies. So if we look at the clinical efficacy of all the treatments in 2020, you have 2 pathways. You have VEGF pathway and you have the immune checkpoint pathway. And in the VEGF pathway, you have drugs in first line, second line. The response rates are the highest with lenvatinib, and also with atezo-bev, the response rate is about 27%. So where you need a quick response, I think this is where one would go for. And in second line setting, you have all of these drugs available with a survival of ranging from 10 to 12 months. But if you sequence with the sorafenib followed by regorafenib, I think for all those patients who do get it, the median survival is above 2 years. The overall survival with the atezo-bev, like I said, is not reached. With immune checkpoint inhibitors, the response rate ranges from 15 to 33%. 33% is with anti-CTLA antibody and the checkpoint ipilimumab and nivolumab. And the survival is about 23 months. It's a phase 1B study. I think this is a very important slide, because this is what you need to look at when you're seeing the patients in the clinic. So if you see, if you look at the atezo-bev, I put the cost, and I've also put the patient assistance program for each of these that you have. And taking the patient assistance program into consideration, with atezo-bev, the cost is almost 5 lakhs. And if you look at sorafenib, it's 8,000 rupees. With lenvatinib also, it's 80,000. And most of our patients, like I said, would be on 4 milligram, alternating with 8 milligram or 8 milligram. The cost comes around to about 50 to 60,000 rupees for lenvatinib. That's per month. It's a huge undertaking, because once the patients start on these drugs, they have to continue forever. So in majority of my patients, I am actually starting them on sorafenib. What I do is I start them on 400 milligram once a day and then slowly escalate it. So the cost implications, if you don't have insurance, is huge. With pembrolizumab, you take it, this is 4.2 lakhs, 2.5, 1.4. And, to shell this out week on and week off, in every 2 weeks, every 3 weeks is quite stressful for our patients. So ideally, one would like to give atezo-bev followed by maybe sorafenib, lenvatinib. From the colorectal data, we know that the VEGF inhibition carried on in second line, third line does prolong overall survival. So probably, you could maybe give regorafenib second line and then have lenvatinib or sorafenib third line. So we still need to know what the right sequence is. What are the most optimal sequences to prolong the life of our patients? For majority, what I do is I do start with sorafenib because the atezo-bev combination and the dose of bev is very high. I do have a patient currently on this, but they are getting just 400 milligram of bevacizumab, not 15 milligrams per kilogram. So I think we need to generate our own data. So there's so many of you here. I think 74. I would urge you that if you're seeing patients with HCC, we set up a database and we collect the data so that because my feeling is that most of our patients do not tolerate the higher dose of lenvatinib or sorafenib, and I think the lower dose of bevacizumab may be good enough. But unless we generate that data, we will never be able to tell the world. So I'd like to acknowledge Medscape, Dr. Javle, and the GI New York debates from where I've borrowed some slides. Thank you. Okay, so shall we take the questions?
Yeah. Thank you very much for your talk as well. I think we got 3 questions.
Okay, will sorafenib work post progression on atezo-bev? If not, what is the ideal second line? So, this is a VEGF inhibitor. And like I said, I'm extrapolating for colorectal that we know that, second line, third line VEGF inhibition does work. And in fact, when you stop bevacizumab, there is rapid progression. And I've seen in a few of my patients that when you stop the VEGF inhibition, there is a very rapid progression. So we don't know the answer to that, but I think atezo-bev, probably I would give ramucirumab or regorafenib second line and then ramucirumab. We don't know what the right combination is. So, but yes, in affording patients now, we are starting with atezo-bev.
Okay.
So the next question is, I'm not able to go up. Got up. So experience in lenvatinib or sorafenib in child PU B or C. So C is definitely contraindicated. I would not give it. And in B, I would go with the lower B, 7, where the score is 7, 8, and a patient is fit, is walked into my clinic. It's the PS01. And but if they come in a wheelchair with huge amount of ascites, bilirubin on the higher side, I would not consider any of these drugs because these drugs are quite toxic. And again, like I said, we don't have much data on it. We must generate data. Sorafenib, I do have experience because I have slides from 2014. I think we had about 30, 40 patients with child PUB that I had given sorafenib to. And yeah, you also have experience with that?
Yeah, I think it's the same. What I was saying is that there's a problem with second line with even lenvatinib also. There's no data if you use lenvatinib in the first line, and then what to use. So I think the first question, like what to use after atezo-bev, the same is what to use after lenvatinib. And I think it's only collaboration that will give us, or you have a real world experience and
Absolutely.
Then try to collaborate and then try to answer those questions.
Yeah, I mean, colorectal is a common cancer, so we are learning now. And after a decade of only sorafenib, we suddenly got so many drugs. Now we need to learn how to optimally use them and sequence them, I think. So
yeah, most of our patients come in child PUC B. Hardly any are in A. I mean,
no, and so they don't go to second
question. They won't. Most of them won't.
I agree. Any experience with atezo-bev? Like I said, I have about 3 patients on atezo-bev, and in a couple, in some, I mean, the insurance covers everything, so they're getting 15 milligrams per kilogram. but as per the trial dose. But this other patient, we've just giving 400 milligram because I mean it's quite expensive, these drugs. So let us see. I mean the patient is responding well right now.
I think there has been data in different malignancies where bevacizumab should be used really in 50 milligram per kg, or low dose bevacizumab is as effective as the same. Similar data is being talked about the nivolumab also. But I don't know who's going to support the trial.
No, and I think in colon we know that 7.5 milligram is as good as 15 milligrams per kilogram. So we know from other cancers. And the thing is, this is a Roche-driven trial, so they are not going to go with lower doses. They are going to go with higher doses.
Yeah, the Chinese trial, nivolumab was 30 milligram. Who is going to give a trial of 30 milligram? Nobody. Nobody is going to sponsor.
Yeah. So these patients I have got, they're all on 1200 milligram of atezo. And I think the patient assistance program is again 1+2. So they get 2 cycles free. So within 3 cycles, I know that they're responding or not responding.
Right.
So they only have to pay for 1 dose. So again, it's if we didn't have these assistance programs, it will be quite tough. So any rationale of using lenvatinib in different doses in HCC, RCC, and thyroid? Oh God, I don't do RCC and thyroid at all. So thyroid, you give 24 milligram, isn't it?
Yes, 18. Most people come down to 18.
18. But HCC is a different disease. The liver is not normal. So in RCC and thyroid, your liver is normal. Most of the patients would have an uncompromised liver. Most of our patients with HCC will have a compromised liver. So that's why I think most of my patients are, none of them, I got one patient on 12, got quite a few, but most of them are on 4 milligram alternating with 8 milligram. And another one is alternate day 4 milligram. He's an 82-year-old gentleman, but he crashed his AFP from, I don't know, 10,000 to 200 on lenvatinib. So I think for him, even 1 milligram of lenvatinib will be good enough. So I've reduced the dose right down. Actually, he's taking it twice a week. So and mainly, I think the issue was hypertension with him. But he's 82. He's back in Cochin. He's doing very well. So very good result. I think one of the best results I've had with lenvatinib. So, what is the role of FOLFOX chemotherapy? Although recommendation
is Venkata Babu has. There's the next. Yeah, I've seen it. Same. Yeah, you continue.
So again, I think it tends to work more in hepatocholangiocarcinomas.
Yes.
In hepatocellular, I have used it. I've used gemcitabine as well. But again, with a fit patient, normal liver function, and I've used it when I was in Cambridge. This patient had progressed on sorafenib. He didn't have anything else, and the patient was fit, normal organ function. So when we gave gemcitabine, and the patient responded amazingly well. Given FOLFOX to a couple of patients, but I think they were hepatocholangiocarcinomas, not standard. So yes, I mean, once you failed all these treatments, then you can try it. And if your patient can't afford any of the immunotherapies, I think if a patient is fit, I would go for chemotherapy, because some of them do respond wonderfully. So can we use lenvatinib in second line after sorafenib? So I have used lenvatinib second line, mainly because the other options were expensive. Like I said, we have to collect this data, and the patient is doing well. There's no data supporting, but again, the only thing is VEGF inhibition. It's a different drug. The response rates are higher. So say like in renal cell cancer, you give sunitinib and then you give sorafenib second line. And that's how we generated the data with real world evidence in renal cell cancers as well. So I think hopefully, I think it's worth giving it a shot. So experience with NIVO and concurrent SBRT. So I have no experience with that actually, but there is some data coming out with the checkpoint inhibition and radiotherapy. Do you have any experience, Padmaj, on with SBRT?
No.
No, so I don't know actually. I'm sorry. So taking into account the financial toxicity in a country like ours, what is the best second line if patient progresses on sorafenib? So, I showed you this slide, which is, the cost wise, the second line best would be regorafenib. I mean, it's 1.4 lakhs, or lenvatinib. Everything else is so expensive. It's really tough. And I think after sorafenib, I have gone on to lenvatinib mainly for cost reasons in some of my patients, and it hasn't worked in majority of the patients. Only one patient. Yeah.
Sometimes best supportive care may be good.
Yeah, and if they're towards higher side of Child-Pugh BC, then best supportive care is the only option. Does immunotherapy activate reactivation of Hep B or C? So I think all the patients that we've given it to, we have made sure that the viral load has started coming down with treatment. And nowadays, with Hep C, you have very effective treatments. You have pegylated interferon, ribavirin, and same for hepatitis B. They have very effective drugs. So you have to treat it, and once you know that your viral load has started to come down, you can go ahead with your treatments. But if a patient has a raging infection, I'd probably go with sorafenib or lenvatinib lower dose, and not go start with immunotherapy in this patient. Maybe reserve that for second line. So where does SBRT fit in? So again, it's very similar to radioembolization. So and there is good data coming out with the SBRT in HCC now. But as long as the patient has liver limited disease, that's when I would consider. If patient has extra hepatic disease, you have to consider systemic treatment. But good data coming out with SBRT in HCC. And the other thing in HCC, which I have seen only in India, and it's good data actually, it's been published as well, is just giving SBRT to the portal vein thrombus, where it decompensates your liver, and at least the patients have relief of ascites and the liver function improves. And I think Dr. Kataria, the Medanta group, has published this. Dr. Anand at Max, he does a fantastic. So a lot of centers around the country are taking it up now. And when I came back, I realized that nobody in the West was doing it. But that doesn't mean that it's wrong, because you see the results in your clinic. With just now, I think Tata is doing it now. Everybody is doing it. Just SBRT to the portal vein, especially if patients have a thrombus. So that is where I see a very good role. Then at what level of platelet count we should reduce the dose of lenvatinib? So I think it's very subjective. If patients goes down to platelets less than 100, I would reduce the dose. So I have a patient who's post renal transplant actually on lenvatinib, and he's on 4 milligrams alternate day. And the only problem that I've had with him, he's on mycophenolate mofetil, is platelet count. So, and he's currently on 4 milligrams alternate day, mainly because of platelet count. So, I think you have to get the dose right. It can affect the platelets. Yeah. So, my threshold is 75. I try and keep it above 75 to 100. So, do you ever use immunotherapy in first line in HCC? Yes, like we discussed, atezolizumab and bevacizumab, you can use first line in HCC. And in this trial, about 67% were PDL1 positive in this IMBREV trial, but that is not a criteria to select patients for immunotherapy. I think you give it to all comers. So, in patients with Hep B, C positive being planned on Nivo, is there any suggested time to keep on antiviral therapy before starting immuno? So I think if a patient has an active infection, I would not start them on immunotherapy, because it's going to just reactivate it and probably flare it up. I would have it under control. So in these patients, I tend to deliberately start on sorafenib or lenvatinib, and then reserve this for second line. And again, we don't know what the implication of sequencing is, giving checkpoint second line, or we still don't know what the right sequence is. And again, I want to hear from our experts as well this Friday. Have you seen immunotherapy or lenvatinib-induced hepatitis in HCC? I've seen both actually. I've seen terrible autoimmune hepatitis in fact, on a patient on a clinical trial with early breast cancer, and so it was quite tough. So this lady actually was on very high dose of steroids, underwent multiple liver biopsies. We couldn't get on top of it, and the high dose steroids itself has another effects on diabetes, pathological fracture, osteoporosis. So yes, immunotherapy itself can cause autoimmune hepatitis, which can be quite severe. So that's why one needs to keep track of that. Lenvatinib induced hepatitis also we have seen. Again, we modify the dose accordingly. So, sorry for deviation from topic. What is your experience with immunotherapy in intrahepatic cholangiocarcinoma? I haven't used it in intrahepatic cholangiocarcinoma. My choice of treatment is gemcitabine cisplatin in cholangios, first line. And second line, we tend to do NGS, and there's excellent data now with GemCis, paclitaxel, and also with the IDH mutation and now BRCA mutation. So I recently had a patient with gallbladder who had a BRCA mutation, and it has been described in 4% patients with cholangiocarcinoma as well. I think we're going the pancreas way with the biliary tract cancers as well. What is your experience with regorafenib in HCC? So I have used it in not many patients, because very few patients of mine have gone on to second line, third line. Exactly what Dr. Padmat said, most of the patients, when they come, they are child PUB already, and very few of our patients will actually go on to second line, third line therapy. In clinical trials, you have 50% patients going on to second line. So in real world, my feeling is you'll have about 20 to 25% plus patients going on to second line. So I have limited experience. I have a lot of experience with regorafenib in colorectal cancer, with some good responses, but I'm just not impressed with the drug, both in colon and HCC. And it's quite toxic as well. How do you differentiate intrahepatic versus HCC, as both have triple phase washout? Do we need biopsy? Yeah. So that's why I said HEPAR1. You can do immunohistochemistry, and again the LIRADS grading is quite different. In most of your hepatocellulars, you may have a history. Most of the HCCs that I see are diagnosed are patients who've been followed up for chronic hepatitis for a long time, and on serial ultrasound or MRI, you see some new lesion, and that's how you diagnose HCC. Intrahepatic usually presents differently. And yes, I agree with you. And you could have a hepatocholangiocarcinoma. So where you would want to treat them with chemotherapy and not treat them with any of these drugs, because these drugs are not going to work. So experience of using lenvatinib with nivolumab. So why would you use, so in advanced cancer, always remember one thing. This is the thing we learned from breast cancer. Do not use two effective options at one go. What you want to do is you want to hold the hand of your patient for a long time. And the only way you can do it is when you start the patient, you already have a plan for this patient for second line and third line. So always assume that your patient is going to progress. And when they progress, yes, they may not be fit enough at that time, but you have to plan for second line and third line. So I would start with lenvatinib and maybe reserve nivo for second line. I would not give both of them together. No. Any Indian data comparing efficacy of reduced dose sorafenib compared with standard to avoid the hand-foot syndrome? So, I should have looked it up. I'm sorry. I haven't looked up any Indian data. But I'm not aware of it. But I'm hoping somebody has published it. I wanted to publish in 2014. And the efficacy was not any different, because in most of the trials, you're reducing the dose in about at least 33 to 50% of patients with sorafenib. So, and despite that, you are seeing a survival benefit. I'm not aware of any Indian data, but I think I have a feeling I've seen it published. I will read it up. So if you're aware of fit, just put it on the group now itself so that we all know. So we have a recent Lancet Japanese center data for lenvatinib pembro for gastric cancer. Yeah, first and second line with good overall response rate. Agree. Can we expect similar results in HCC? Yes, probably. But again, we know a lot of these drugs which work in one cancer may not work in another cancer. So you have to use the drugs within and there are trials going on with the combination of VEGF inhibitors and checkpoint inhibitors. So I think we are waiting for those. And there's a phase 1B study with lenvatinib and pembrolizumab in HCC. And but again, we need to wait for overall survival or at least progression-free survival data. I would, again, like I said, I working in a resource-limited setting like we do, I would not want to use two effective combinations immediately, unless we know that we have good second and third line options available. Any suggestions or indications of liver biopsy in patients with cirrhosis and imaging suggestive of HCC? So, if the patient has a normal AFP, or even if it's less than 200, I tend to push for a biopsy. The reason is that even if they can't afford the expensive NGS testing, we can have some tissue for research and also have tissue to be sent for NGS within India as well. And so it's so that is why I think as oncologists, as medical oncologists, we should try and do biopsy in our patients so that we learn more about the biology of the tumor in our patients. Yes, HCC can occur in patients without cirrhosis. Not all patients have cirrhosis. You can have non-cirrhotic HCC as well. So molecular testing, yeah, that's the reason why I said we should do a biopsy, because with all these new targets coming up, and there are some fantastic data in HCC as well, which is coming up in molecular oncology. So we should try and do a biopsy and do molecular testing if possible. Great. I think that's all the questions done.